Hello everyone, this is Love and you are watching my channel, and today we will be talking on the management of the seizure and epilepsy chapter. So how to approach a patient with the seizure. So always whenever patient come to you, ask the history. So in history you should ask that from how much time the symptom has occurred and what are those symptoms before attack. So it is simply saying that if any presence of aura or not, so there is any kind of aura present or not, that the patient gets a warning sign before the attack commences, and what are the symptoms after the attack, and is there any post-icterial defecate or not, and what are the symptom is in the during the attacks. So these are the things you should ask, and also ask for the any precipitating factor like the sleep deprivation, emotional traumas, drug withdrawal, like the music, light, or the fever. So these are the precipitating factors. So these are present or not. Also ask that if there is any kind of family, so if there is a seizure history in any of the family member or not. Also ask for the any known CNS disease the patient is having, or if any known metabolic disease the patient is having, ask for that. And take the drug history, that whatever drug it takes, so that you can rule out that the seizures are due to drug or not. So these things you should ask in the patient. So in what we will do in a physical examination. So basically in the physical examination, you should always do the general physical examination. So in general physical examination, generally you should see for all of the body system. So that is similar in case of the any kind of the disease or for any patient. And you should you should see for the any sign of infection or not. So sign of infection, like if any in the body, in any body part, if there is a kind of the boil, or if there is a acne in the face, or if there is any pus point in the body. So these are basically the source of infection. So these are present or not. Also see if there is any kind of systemic illness is present or not. So systemic illness sign and symptom you can see in the patient. And in the skin you may actually find out the some neurocutaneous lesions. So you can see like the presence of the neurofibromatosis or not, neurofibromatosis, or in the particularly in the chronic liver disease, you will have the different kind of the skin lesion, like the spider navy, and there can be ascites. So see those things also, as we know that in the chronic liver disease there can be the hepatic encephalopathy, and hepatic encephalopathy can lead to the seizure. So to rule out that, you should also rule out the CLD from the skin manifestation. And also see if there is any organomegaly or not. So organomegaly. Also see that the patient, if the patient is basically the children, you should basically see the height for age. You should see the weight for age. And yes, you should also see whether the developmental milestones are completed or not, if the patient is a children. There should be also the testing of the mental status. So the mental status assessment is necessary. Another thing, you should always try to see that there is any kind of the visual dysfunction. So testing of the visual fields. And also see there is any kind of a deep tendon reflexes, or so any problem in those kind of the motor function. So screening of the motor function can be done. Screening of the motor function. Basically this screening of the motor function will tell you about the status of the CNS. So screening of the motor function can be done. You can do the gait test. You can ask the patient for the deep tendon reflex. So do deep tendon reflex. You can do the stretch reflex. So these are the things which we should do in a patient of the seizure. Now what are the investigation we will do in the patient of the seizure. So investigation that you should send for that, first of all you should send for the routine blood test. So routine blood test include basically the electrolytes in the blood, and you should also go for the arterial blood gas analysis. So arterial blood gas analysis in the electrolytes, basically you will see for the sodium, you will see for the potassium, you will see for the calcium, magnesium. So these are the main electrolytes that you should test in the blood. And arterial blood gas analysis, you should see for the pH, bicarbonate level, and you should also see for the basically the partial pressure of carbon dioxide, partial pressure of O2, as actually this pH will help to see that if there is a presence of any metabolic acidosis or not. And these electrolytes level are very essential, as the hypocalcemia leads to seizure. And also you will look in the blood for the glucose level, as we know that the hypoglycemia will lead to seizure, hypocalcemia will lead to the seizure. In the blood you can also do for the liver function test and the renal function test. This liver function test basically you will do to rule out the hepatic encephalopathy, and renal function you will also do for the actually renal function test. Basically you will do to actually rule out if there is any renal pathology and that is affecting the CNS. As we know that if there is in case of the CKD or in case of the AKI, sometimes the urea accumulates, and this urea gets been entered in the brain, and that will ultimately cause the pathology in the brain, and that's why that those pathology can lead to the seizure. So you should always do the renal function test, liver function test. So every test you can do from the blood. The more test you can do in the blood for the screening of the toxins. So screening of the toxins or any drug abuse. So some are the drug like you can morphine or the hashish. So morphine, heroin, that can be that those drugs, and the marijuana. So marijuana, morphine, heroin. So these drugs like the cannabis. So these are the drugs which can you will do screening of those drugs in the blood, as these drugs can actually alter the status of the brain and may lead to the seizure. And also you will do the lumbar puncture. This lumbar puncture is especially done to actually rule out the different condition like the encephalitis. You can rule out the encephalitis, you can rule out the meningitis, and it is actually and the lumbar puncture can tell you very many things, as in the CSF you can access the many things in the CSF. So these are the mandatory tests that you should do. And also do the EEG. So the main diagnostic test to rule out actually what is the test, that test will tell you what kind of the seizure is the patient having. So to confirm the clinical symptoms with the real investigation, you will do the EEG, so electroencephalogram. So this is the test that you will do, and I have already said you what are the findings of the EEG in different kind of the epilepsy in the previous videos. And also do the brain CT scan or the MRI. So brain, CT or MRI. Basically this brain or CT MRI will help you to rule out any kind of the tumor is present or not, or any kind of the malformation is in the brain is present or not. And so these are the investigations that you will do in a patient of the seizure. While talking about the treatment of the seizure and epilepsy, always treat the underlying condition if they are present. So like if there is a metabolic disturbance, some kind of metabolic disturbance like the hypoglycemia or there is a hypocalcemia, then you should first of all treat those kind of metabolic disturbance. And you should avoid the use of the illicit drug use. So if any drug is causing you the seizure or epileptic attack, or after the drug use you have that kind of attacks, then you can avoid the drugs. And yes, also treat the any kind of CNS lesion, either that is a tumor, abscess, infection or malformation. So treat that kind of CNS lesion and avoid the precipitating factor as much as possible, like avoid stress, take proper sleep, do exercise, yoga, and take the counseling session from the psychiatrist. And also take the prophylactic anticonvulsant if you are known case of the convulsion. So let's talk about the choice of drug in different kind of seizures. So in basically in different books there are written like the first line treatment, second line treatment, but I will follow the Harrison textbook, basically the Harrison 20th edition, and there it is not written that this is first line, this is second line. It is like that these drugs are the best drug for this condition. So let's discuss about those drugs. So for the generalized tonic-clonic seizure, the best treatment are lamotrigine, valproic acid, and those who are actually allergic, or if any due to any condition, if we cannot give them valproic acid, we can use levetiracetam. So these drugs are the best drug according to Harrison. And while talking about the absent seizure, basically the absent seizure are two types. One is the uncomplicated absent seizure, the another can be the complicated absent seizure. So basically in the uncomplicated absent seizure, the best drug is ethosuximide. So in uncomplicated absent seizure, the best drug is ethosuximide. But yes, in complicated type of absent seizure, the drug best are valproic acid and lamotrigine. So valproic acid and lamotrigine are very good drugs used in different variety of condition. And yes, this ethosuximide I have written for basically uncomplicated absent seizure. But for the absent seizure that is atypical, you can go for the valproic acid, lamotrigine and topiramate. So for the atonic seizure or the myoclonic seizure or the atypical absent seizure or normal also any seizure, you can use valproic acid, lamotrigine, topiramate. So these are the basically drug of choice, and according to the Harrison book. For the focal seizure, basically the choice of drug are carbamazepine, levetiracetam, and basically levetiracetam, this is a drug which can be given in those patients which are basically elderly patient. So those are elder patients and who are having any comorbid condition like the diabetes mellitus or the hypertension. So in those patients, basically this drug is a preferred choice. But in the normal patients, you can give those who have not any comorbid condition or those who are not elder patient, you can easily give the carbamazepine. Now another drug are lamotrigine. Here also lamotrigine, you can give the oxcarbamazepine, and you can also give the phenytoin. But yes, remember there are some side effects of these drugs, like the carbamazepine can lead to the anemia, or they can lead to the anemia, hepatotoxicity. It can lead to the leukopenia. Similarly, the lamotrigine can lead to the Stevens-Johnson syndrome. Talk about that if any person is having generalized clonic seizure and if the patient is a pregnant patient, then which is the most preferred drug? Then the most preferred drug is levetiracetam. Now let's talk about the treatment of the epilepsy syndrome. So in the epilepsy syndrome, basically we have the three type of syndrome. They are basically the Lennox-Gastaut syndrome. So Lennox-Gastaut syndrome, and in the Lennox-Gastaut syndrome, the choice of the treatment is valproic acid. Another syndrome is second syndrome is juvenile myoclonic epilepsy. So in the juvenile myoclonic epilepsy, the choice of the drug is basically sodium valproic acid. So same valproic acid, the choice of drug in both Lennox-Gastaut as well as juvenile myoclonic epilepsy. And yes, in the juvenile myoclonic epilepsy, usually you should give this sodium valproic acid lifelong, as you know that the juvenile myoclonic epileptic patient will have the juvenile myoclonic epilepsy in their childhood, but when they become adult, they can have the generalized tonic-clonic seizure. So that's why the drug should be taken lifelong. Now another epilepsy syndrome is mesial temporal lobe epilepsy. And in the mesial temporal lobe epilepsy, basically the choice of drug is not the treatment is not mostly medical treatment. We will basically do the surgical treatment. So surgical treatment is done, medical are not effective. So as there is a hippocampal area sclerosis of the hippocampal area, or we can say there is a fibrosis of the hippocampal area, so basically we will surgically excision of sclerosed part of hippocampus. So this is the basically surgery that is done in case of the mesial temporal lobe epilepsy. There is one more drug that is given in the Lennox-Gastaut syndrome, and that drug is known as Lennox-Gastaut syndrome. So there is one more drug. One drug we have already studied, that is valproic acid we can give, and there is one more drug that is known as rufinamide. So this rufinamide also can be given in the Lennox-Gastaut syndrome. So what is the protocol for the drug anticonvulsant therapy in the case of epilepsy? So you should always start with the best drug for any kind of epilepsy. So start with the low dose, and gradually you can increase the dose to effectively control the seizure, and also check the compliance that drug which you are giving, that route which you are giving, that is suitable for the patient or not. And if one drug fails to show the response, then you can go for the alternative best drug, and try at least 3 drug single before doing combination, and you can combine at least 2 drug if this therapy fails. Let's talk about the status epilepticus. So status epilepticus in the previous days, in the previous books or previous edition of the books, usually it was said that any seizure that lasts for greater than 15 to 30 minutes, then we will call it as a status epilepticus. But nowadays the time boundary has somehow reduced. Nowadays it is said that if any seizure lasts for greater than 5 minutes, then we will call it as a status epilepticus. So there are various definitions of a status epilepticus. Let's see. The first definition is that if there is a continuous seizure, repetitive discrete seizure, and there will be impaired consciousness in between the seizure, or we can say that there is multiple episodes of the seizure and without gaining of consciousness in between. It means that you are having a seizure now, and after 4 or 5 minutes you are having a seizure, and in between the seizure you have lost your consciousness. So such type of repetitive attacks which lead to the loss of consciousness between the attacks, and such type of problem is known as status epilepticus. Yes, in a status epilepticus, basically the seizure can be the generalized convulsive status epilepticus and non-convulsive status epilepticus. But in the non-convulsive status epilepticus, the problem are usually not evident, and that's why it is not a medical emergency. So it is not a medical emergency, as there is no any kind of convulsion in the non-convulsive status epilepticus. But while in the case of the generalized convulsive status epilepticus, there is a violent kind of the convulsion, and that is due to that violent convulsion there are various problems. We will see that, and that's why this generalized convulsive status epilepticus is taken as a medical emergency. So whatever the management we will talk about, we will basically talk about the generalized convulsive status epilepticus. So let's start. So we will basically study about the generalized convulsive status epilepticus management. So before studying that, let's see what is the problem in this condition. So in the generalized convulsive status epilepticus, it is a medical emergency, and the main problem is that there is a cardiovascular system and respiratory dysfunction, there is a hyperthermia, there is a metabolic derangements. Why there is a cardiovascular and respiratory dysfunction? The main thing is that in the seizure activity, there will be the generalized convulsive movement, and due to the convulsive movement, due to the tonic movement, there will be increased muscle spasm in the body, and due to which there will be intense muscle spasm in whole over the body, there will be the hyperthermia, that the body temperature will get increased, and there will be muscle destruction. Another thing, there will be respiratory and cardiovascular dysfunction in the way that usually in the generalized convulsive status epilepticus, the mouth are the closed, and due to the closed mouth, the clenching of the teeth and the tongue fall back. Due to the fall back of the tongue and the secretions, they block the airway, and due to which there will be respiratory dysfunction. And this all respiratory dysfunction, the hyperthermia, will lead to the metabolic derangements, and these metabolic derangements, when occur due to the prolonged seizure, will irreversibly lead to the neuronal injury, and later on it may cause the damage to the central nervous system also. Now, what is the cause of basically the generalized convulsive status epilepticus? So the cause can be, let us suppose if you are a patient of the generalized tonic-clonic seizure, and you have left the drug without the advice of the doctor. So as a result of the withdrawal of that drug, that is anticonvulsant withdrawal, you may have the status epilepticus. Or if let's suppose the doctor has given you drug, but you can't take it, it is not compliant for you. Let us suppose the doctor has tell you to take everyday intravenous drug, but your home is far away from any hospital, so it is not a compliance, that drug is not compliant to you, that every day you can take the intravenous route. Or let us suppose the doctor has advised you to take intrarectal, in the rectum you should take drug, but you are not so much compliant to take the drug in the rectal route. So due to that non-compliance, if you are not taking the anticonvulsant, and that may lead to the status epilepticus. Another thing, if there is a metabolic disturbance, so let us suppose if there is a some kind of acidosis or any condition like that, then those will actually precipitate the seizure. They will decrease the threshold of the seizure and will lead to the status epilepticus. Another thing, if there is any drug toxicity, or if the epilepsy is refractory, it is not treated by your usual dose of that drug, or the drug is not working for that epilepsy, then such type of epilepsy is refractory epilepsy, and in that case you may have the status epilepticus. Or if there is a CNS infection or the tumor or the head trauma, they will basically decrease the threshold of the seizure, and you will have the epileptic attack most of the time, and will lead to the status epilepticus. So these were the cause of the status epilepticus. Now let's start the management. So as it is a medical emergency, so unlike any kind of management, you should always start the treatment in the form of correcting the airway. If there is a so you should ensure that the airway is clear or not. So airway clear insurance, and see that the patient is breathing or not. So breathing patterns, you look for the breathing patterns, and see that the patient is having the what kind of blood pressure he has. So look for the blood pressure, and you should also look for the pulse. So you should look for the blood pressure, pulse. So in every kind of the management, emergency management, we should always go for the airway, breathing and circulation pattern. So for the airway, ensure that the airway is clear or not. Ensure that the breathing pattern is okay or not. So he is breathing, what kind of breathing pattern is there, okay. And you should also ensure that what is the blood pressure. So see, if from C there is a circulation, so you are checking the circulation of the patient. So see the blood pressure is what is the condition of the pulse. And once you ensure these three things, so in circulation you can start the normal saline drip. Also see if any cause of the, sometime what happens, the seizure can be due to the hypoglycemia or the hypocalcemia or the hypomagnesemia. So check first see levels of calcium, glucose, magnesium in blood. So you should check these levels, and if there is a hypoglycemia, then correct it by giving 50 ml of 50% dextrose. If there is a hypocalcemia, then correct it by giving the calcium gluconate. So this kind of correction is required immediately, as these kind of things like the hypoglycemia and hypocalcemia will precipitate the seizure. So always you should look these kind of things, and also see the nutritional status of patient. So let us suppose that if the patient is alcoholic, or if the patient is of poor nutrition, or if there is a poor nutrition, then you can administer the thiamine. So thiamine, you can give the thiamine intravenously at 250 mg. So these are the things you can do in the basic management for the life-saving management in the patient of the status epilepticus. So let's study the anticonvulsant therapy for the status epilepticus. So the anticonvulsant therapy is like this. First of all, you should establish the venous access. So start the anticonvulsant therapy from the benzodiazepines. So the benzodiazepines will be given first of all the intravenously, and it will be given for just the patient, to make the patient stable or calm. So it is given in the form of, like, if we are giving the lorazepam, then it will be given in the 0.1 mg per kg, like this. And similarly we have midazolam or clonazepam. So whatever is available to you, you will give that, and repeat once if there is a no response over the 5 minutes. So you have given the drug, but after the 5 minutes also there is no response, then you can repeat the same dose once again. And so these actually these agents, the first line agents of the benzodiazepines, they will work for a very short time. So actually we will add the phenytoin or valproic acid or the levetiracetam. They will actually cause the long-term seizure control. So the phenytoin is given like 20 mg per kg, and valproic acid is given 20 to 30 mg per kg, or the levetiracetam is also given 20 to 30 mg per kg. It means the dose is almost same for the either phenytoin or fosphenytoin or valproic acid or levetiracetam, but we will either give phenytoin or fosphenytoin. So you can give anyone. And once we give this phenytoin plus the first line agents, then also the seizure didn't control. Let's suppose that the 10 minutes has passed and now also the seizure is not controlled, then you should actually call for help. And if there is a facility of the ICU, then you should always go for the general anesthesia by the propofol or the midazolam. But yes, if there is a urgent ICU is not available, you can give the medicine like the phenobarbital 20 mg per kg intravenous at the rate of 60 mg per minute. And if it is not controlled by this, then again you can add the extra dose of phenobarbital like 10 mg per kg at the rate of 60 mg per minute. And again, if after giving these two doses of the phenobarbital, though it is not controlled, then only one option is left now, that you have to give anyhow general anesthesia. So either if you have a facility of ICU, then you will already actually go for the intubation and start general anesthesia. But if the urgent ICU is not available, then you can initially give the phenobarbital, and if the phenobarbital also cannot control, then at last anyhow you have also to go for the general anesthesia. So this is actually treatment pattern of the status epilepticus.